Welcome to a new episode of AirLife Clinical Conversations. Today we will be discussing the SuperNO2VA end-tidal nasal positive airway pressure mask ventilation in the OR and PACU. With us today we have Dr. Lorraine Foley, Anesthesia Medical Director at an ambulatory surgical center and Executive Director for the Society of Airway Management. My name is Eli Manna. I'm a respiratory therapist and I'll be your host today. We're going to discuss with Dr. Foley her experiences and considerations using the SuperNO2VA inside the OR, outside the OR, and post-operatively in a PACU. Dr. Foley, thank you for joining us today.
Thank you for having me. It's a pleasure to talk about this.
Likewise. So SuperNO2VA mask, so instead of calling it SuperNO2VA end-tidal nasal PAP, we're just going to go with SuperNO2VA just for brevity. So Dr. Foley, what is the SuperNO2VA mask? Or SuperNO2VA system, and how does it work?
Okay, so the SuperNO2VA is a nasal CPAP that has been around for quite some time because patients with obstructive sleep apnea are treated with nasal CPAP taken home with the machine. What this SuperNO2VA now is, it allows us to be able to use it without a CPAP machine, and it's one unit that actually seals just, and here's an example of it, that will seal around the nose so that it will cause positive pressure using 10 liters per minute, 10 to 15 liters per minute flow, either using your anesthesia machine circuit, or actually what they have come up with is what's called the Jackson-Reese with the pop-off valve as well, that you can use for transport with the patient.
Yes. Okay, so basically what it does, it provides positive airway pressure to stent the airway open.
Correct. So what it's doing is studies have shown, not with the SuperNO2VA, but with other nasal CPAPs, is shown that especially with patients with obstructive sleep apnea, that what happens is that at 5 centimeters of water, you're transmitting about 3 centimeters into the trachea. Mm-hmm. But at 10 centimeters of water, you're transmitting 8 centimeters to the trachea. So basically what it's doing is, but nasally, it's stenting open the soft palate, versus which then stents open the whole airway. Yes. Unlike the difference is unlike a full face mask, like a BiPAP type of thing. Yes. What's happening is they're now pushing air in the mouth as well as retropharyngeal. But the problem with that is studies have shown that most of, especially for obstructive sleep apnea patients, where I think this is really indicated, is that the collapse of the airway is actually retropharyngeal in the soft palate. So using the nasal CPAP, SuperNO2VA, that overcomes that obstruction versus a full face mask one.
So basically from a clinician's workflow, is it simpler to apply a SuperNO2VA mask to a patient rather than having capital equipment brought into the OR and extra circuits and masks and what have you? And gas connections as well. Right.
Yes. So this is a very portable. What's key about this, again, like I said, is either if you're in the operating room, what you can use is you can use your anesthesia circuit. But with this SuperNO2VA, all you need is the anesthesia circuit and 10 liters per minute of oxygen. So that means you can also use your oxygen tank if you have that. So if you're outside the operating room and let's say you're somewhere where they don't have oxygen on the wall, you can use the tank, and you're not going to run out of that oxygen quickly.
Okay, that's perfect.
Yeah.
So then, in your practice, what are the clinical applications where you do use SuperNO2VA besides for obese patients?
Okay, so really for what I find using the SuperNO2VA is for pre-oxygenation. So if I'm having a patient that's possibly a difficult intubation, and I want to pre-oxygenate them. I can use it for pre-oxygenation so that that same patient at the end of the case, I will apply that back on and put it on immediately post-operatively. This way I can now take that patient to the recovery room from the operating room on the stretcher, because all I need is an O2 tank, to the recovery room until they're awake enough or they don't need the nasal CPAP anymore. But it's usually, I mean, the main clinical indication, someone like myself that doesn't have sleep apnea, it would be good to use, but it's really important for large patients, obstructive sleep apnea, that collapse their airway as soon as they're sedated at all. This will actually help oxygenate that patient.
Perfect. So then do you feel that that has any impact on patient outcomes, whether pre-op or even post-op? Do you feel like it has an impact on the outcomes?
Yes, tremendously. So basically, so one of the things is with preoperatively or prior, if you're inducing this patient, pre-induction is pre-oxygenation as well. And if you plan to intubate the patient, you can now apneic oxygenate this patient as well. So you keep the nasal CPAP on, SuperNOVA on while you are intubating the patient. It does not get in the way of intubation.
True.
So once the patient's intubated, so one, you now have long apnea time so that if the patient's a difficult airway, you're not going to have that patient desaturating on you.
Sure.
So that's number one. Two is postoperatively, is that, studies have shown patients that might be still sleepy, those especially with OSA are very susceptible to any narcotics. You have still anesthetics on board if you've intubated them. So they are more likely to obstruct. This allows me to extubate that patient in the OR and bring him to the recovery room safely. Actually, the PACU nurses, recovery room nurses, like it because now they're not worrying, telling the patient to take a deep breath because they're breathing, and now with the CPAP, they're taking nice breaths, maintaining their oxygenation.
Sure.
As well as then in the recovery room, there's many times where the nurses come to me and said, hey, this patient's not doing well, they need to be intubated. So what I will do, and again, it could be because residual narcotics, residual anesthetic, even actually some slight pulmonary edema, not extensive, but something that you're kind of tenuous about intubating that patient or not. I will put this on, the SuperNOVA on, and it actually helps prevent intubating those patients.
It's funny that you mentioned that, Dr. Foley, because I was going to ask you, do you feel like the SuperNOVA had prevented the intubation of some of your patients?
Oh, definitely, definitely.
Okay. So what are some contraindications that you can think of for using the SuperNOVA?
So one of the things I think, and is talking to other people that have used it, especially for ENT cases when they're doing direct laryngoscopy, it's not a contraindication. The problem is that the SuperNOVA is compared to the high flow. It kind of gets into the ENT surgeon's way when they're doing direct laryngoscopy. And the other thing is it is high pressure, 10 centimeters of water, so you have to be careful if there's any contraindication that might dissect the airway. So if there's any surgery that you might not want to do positive pressure on that patient.
Yes.
So it's any contraindication that a CPAP would have.
Okay. Is there an advantage of a feature that SuperNOVA offers, and that is to be able to use the mask directly with your anesthesia machine?
Yes. I mean, you can just use the mask itself and using the anesthesia machine, especially for even outside the operating room. So or actually in the OR if you're doing deep sedation on patients, right? Yes. You don't need to use this. You have your anesthesia circuit that you can use directly so that by the time you finish the case anyway, and the patient's pretty much awake, so you don't have to worry about transporting them back to the recovery room on this.
Okay. So what are some of the longest cases that you've had to use the SuperNOVA on?
So actually, the other advantage about this whole thing is one of the long cases is basically like let's say a revision of an AV fistula, arteriovenous fistula, for someone who's going on renal dialysis, right? So that, I've done 2.5, 3 hours, up to 4 hours without a problem. The advantage of having this SuperNOVA on that, and especially if someone who has, is going to obstruct, I don't have to manipulate the airway. I'm not going to be putting a nasal trumpet in. I'm not going to be putting an oral airway in. Because you have to be concerned on those type of patients, or even if you're doing an epidural for a femoral FemPop bypass, right? That they get heparinized. Okay. So now you've instrumented the patient with a nasal trumpet or with an oral airway, which everything seems fine, there's no bleeding, and then as soon as you heparinize that patient, now you're going to get in trouble with a lot of bleeding. So this is one of the nice advantages of that you don't have to instrument that patient's airway.
Absolutely. So with the SuperNOVA circuit, the entire system actually, it includes the 2-liter bag, which by itself, it can be a rescue a rescue apparatus that you have in there to where when a patient desaturates or needs rescued, you don't have to stop
Correct.
and grab a bag and what have you. Everything is there for you. How do you feel that that improves your workflow? How do you feel that improves patient safety and so forth?
So exactly. You're right on, because what happens is, sometimes you just oversedate the patient, right? And you're just waiting for them to come back spontaneously breathing. So you actually, it's very simple to mask ventilate the patient. You just close the seal, close the mouth, close the seal, and then you ventilate through this bag. Or if you have the anesthesia machine, same thing, the ambu bag there, you can mask ventilate the patient very easily. The other, when you're bringing that up, the other advantage of using this and taking this patient to the recovery room is because, when you're taking a patient from the OR to the recovery room, you're not monitoring the end tidal CO2. We don't have a machine to do that. So you don't know if they're really, really sedated. How are they breathing okay? If you have an oxygen face mask, what you're doing is you keep on looking for a change, the respiratory change. With this, what it allows you to do is, because you're going to have a good seal, you're going to the ambu bag is going to be blown up, but you're going to see the patient breathing because you're going to be able to see this. So you are actually, not end tidal CO2, but you're still monitoring that patient, and you can still see that they are breathing.
They are spontaneously breathing. Yes,
correct.
Absolutely.
So.
Well, that's great. I don't have any other questions.
Okay.
So let me just conclude then. So as we wrap up today, Dr. Foley, do you have any final thoughts on the SuperNOVA, its use, its applications, or any other thoughts that you'd like to share with us?
So, as you know, I'm working in the ambulatory surgery center. So it's a standalone surgery center. So for me, there's 4 ORs. We do a lot of orthopedics, we do ENT, and so the BMI, our BMI cutoff is 50, and this actually allows me to do higher BMI in these patients, obviously depending on the case, because what we don't have is we need to extubate that patient in the operating room. This allows me to extubate this patient safely, and especially with a BMI of 50 or so, and bring them to the recovery room, because if they remain intubated, number one, what happens is that either I sit there and wait until they wake up enough to do that, that they're fully awake, or if they have to remain intubated, then they have to get transported to the hospital.
Main hospital.
So that has made a big difference on the type of cases and safety of the cases that I can do in the ambulatory surgery center.
Yeah, it makes a lot of sense. Well, Dr. Foley, thank you very much for your time here with us today. Great information. We appreciate it.
Thank you.